7 of Doc Talk Live. We are a health show dedicated to educating our listeners about different health topics every week. And we do this by bringing on medical experts to answer commonly asked questions. Be sure to send your questions through Facebook Live on Wednesdays at 5 p.m. You can find more information about the show on Facebook, Instagram, Twitter, YouTube, and our website, doctalklive.com. That's DOCTALK live.com. Also, you can look for our show on Spotify, iTunes, and iHeartRadio. My name is Dr. Paul Cespedes, and I am hosting today's show. Joining us today, we have Dr. Steve Duffy and Dr. Chris Cotrell to educate us and discuss the topic of abdominal pain, which I'm sure all of us have had multiple times in our lives. Dr. Duffy, Dr. Cotrell, thank you so much for joining us today and volunteering your time. Please take a moment and tell our listeners about yourselves.
Hi, Paul. My name's Steve Duffy. I'm a general surgeon in McKinney, Texas, and I'm from this area. Grew up here in Wiley. And after training in the military and off at school, I came back about 7 years ago and started our practice.
Awesome.
Yeah, and I'm Chris Cotrell, and I've been in the Dallas area since about 2005, and I joined Dr. Duffy in 2018.
Very good. And I'm sorry, the name of your practice?
Advanced Surgical of North Texas, based in McKinney.
Okay. And you have a website?
AdvancedSurgicalNTX.com, and as long as we're doing this, Instagram at Chris Cotrell MD, and I actually have a podcast myself at Dr. Chris the Surgery Guy.
All right, awesome. Well, welcome. And let's just go ahead and get started. Actually, Dr. Duffy, let's start with you. Just kind of quickly, what are some of the most common causes of abdominal pain? I mean, I did a variable, but what do you see?
Thank you, Paul. So, to your point, a very large, broad area of causes for this, and I like to break this down into medical causes and surgical causes. If you're talking about medical causes, this would tend to be things like bladder infections, GI infections, sometimes heartburn, things of that nature. Surgical causes, the more common things you'll see would be things like appendicitis, gallbladder attacks, reflux and hiatal hernias, malignancies sometimes.
Okay.
Perforations of certain organs, so perforations of the stomach or colon being the most common.
Okay. And are there any symptoms that are more concerning that you say, oh, this is probably more serious, or, I mean, is it kind of too hard to tell?
It's really difficult to tell, like over the phone or a phone call, for example, but in general, if a patient's at home and it's causing an inability to function, that's definitely time to go in and see immediate medical help, emergency help. Beyond that, something that's just not going away and is new should be investigated as well. That's pretty general, but the more severe the pain, or if it's accompanied with fever, nausea, and vomiting, that starts to get more serious.
Okay. Now, it's interesting you say that, because, I mean, being in the hospital, we see patients where they just have one episode of nausea, vomiting that morning, and they come in, versus people it's been going on for a week and a half, and they decide to come in. What do you think is, just kind of a general guideline, is a good time to really get it investigated? Because, I mean, that's a huge time frame difference, right? One episode versus a week and a half.
I would piggyback on what Dr. Cotrell was saying. If this is something that's unremitting, that's certainly an indication. Now, if you're talking about just an isolated episode, I would look at the severity of it. If this is disabling pain, like what was described, if it's associated with something else, such as fever, low blood pressure, heart racing,
Okay.
faintness,
Sure.
that's really something that gets our attention. You really do want to get help right away.
Okay.
But in general, unfortunately or fortunately, everyone's different.
Right.
And they're going to have a different worry level to a patient's benefit and detriment. So you'll have people that go to the hospital a lot,
Yeah.
and have a lot of false alarms, and then you'll have people that sit at home very sick for weeks.
Right.
How to address all that? My point would be, if you're worried about it, you should get it checked out as soon as possible. I don't know that I'd put a specific time frame. I certainly wouldn't want patients to get the idea that, I can wait 6 hours and it's okay.
Sure.
If it's bad pain, get it investigated.
Okay, I think that's very reasonable. Good. And then, you know, a lot of people are afraid, right? They're afraid they're going to go to the hospital and they're going to find out something devastating. Oh, what if I need surgery? What kind of pain do you generally would require surgical intervention?
Well, I think hopefully as we move forward in technology and advances in surgical technique, the amount of pain that a patient experiences after surgery and the recovery time has gotten so much better that as we get messages like this out in these forums, that I'm hoping patients will become less afraid over time. We do things robotically, minimally invasively, such that they're home the next day, same day sometimes, and so I'm hopeful some of that fear will go away. But with regards to getting in there and overcoming those fears, hopefully it's just education and just get in there when you have something wrong.
Yeah.
And kind of you have to get over it because unfortunately, scary though it may be, the alternative could be even scarier.
Okay. But there's not like a specific pain somebody can say, oh my gosh, I have a pain like right by my belly button, that probably needs surgery, right?
Yeah, I think it requires too much investigation, clinical judgment. It's not something that you can necessarily just match up, symptom A, B, and C that I read about online.
Sure, right, yeah.
Equals X, Y, Z.
Right, because Google said.
Exactly. That's where the art of medicine and a practitioner with a lot of experience can really help you decide what is actually going on.
Okay, good.
Unfortunately, surgical diagnosis is not best done at home.
Right. Okay, good. I like that.
Believe it or not.
Right. Okay, and then you had mentioned robotic surgery.
Mm-hmm.
So can you maybe discuss a little bit the difference between open, laparoscopic, and then robotic?
Yeah, I'd love to. It's absolute passion of us and our practice. In terms of the robotic platform, basically it's the most advanced thing that you can do right now. So anything that you used to be able to do with a large incision, which is the open surgery, whether it's removing part of the stomach, colon, or small intestine, rerouting things as needed, that can all be done with minimally invasive technique now. So rather than a giant incision going from your ribs all the way down there, you can do small little incisions, not unlike what people associate with a gallbladder and appendix. So you can have major surgery and go home the next day. That's pretty unbelievable. Laparoscopic does have a lot of advantages over open, but it's somewhat limiting. You don't have the freedom of movement, you don't have the ability to do the more complex things, not without huge learning curves and very specialty equipment. So it opens up things much, much wider. A couple weeks ago, it was a weird day, but I actually took out a portion of someone's stomach as well as a small intestine in two different patients back to back on a Saturday robotically, and they both went home the next day.
Wow.
Yep.
Huh.
It's amazing.
That is.
I would add just a couple of things to that as well. It's been interesting. Dr. Cotrell and I both trained in the era prior to robotics existing, and laparoscopy was just sort of coming online. So this is a relatively new technology, maybe the last 12 years or so. When I trained on it in 2011 on the surgical robot, we were fully trained. The technology just wasn't ready yet. And so and I think probably you as well, abandoned it for several years and waited for the technology to catch up. And about 5 years ago, it really hit prime time, and the differences we see in our patients' outcomes and satisfaction is just it's just beyond compare.
Yeah.
And I forgot what the second thing was I was going to add to that.
Okay, no problem. If you think of it, we'll come back.
Yes, sir.
Okay, so we've kind of talked about some of the causes of abdominal pain and then, the different surgeries. But so how do you actually diagnose whether they need to go to surgery or what's going on? What steps do you take when a patient shows up to the ER?
So we have a bunch of technologies that are available, but to be honest with you, the first and best thing and still very valid is physical exam and history.
Absolutely.
So talking to the patient, seeing how their symptoms progress, going on the things that we've trained on, as well as the physical exam. There's a great book that's still extremely valid today called Cope's Diagnosis of the Acute Abdomen. I don't expect patients to read that, but it describes what a surgical emergency belly looks like, and we still use that to this day,
wow.
Even though it's nearly 100 years old at this point.
Huh.
Now, we have a bunch of augmenting technologies so that we can pinpoint where we're going, and especially when we have a robotic platform that can be a little bit more targeted. A CAT scan is obviously extremely helpful, labs, all these other supporting documents, but fundamentally surgical emergencies are still probably best diagnosed with physical exam and history.
Yeah. Huh. Okay. All right. So, when we're talking some of the common causes of abdominal pain, and you mentioned the surgical causes, Dr. Duffy mentioned gallbladder.
Yes, sir.
So, why does the gallbladder suddenly cause pain? You're living your whole life, you hit 40 and bam,
Exactly.
gallbladder pain.
Exactly. It comes out of nowhere, and most time folks are not expecting it, and you end up in the ER with terrible pain, nausea, vomiting. It can be pretty traumatic. Texas is the gallbladder capital of the world. We actually see more gallbladder disease here than anywhere else.
Huh.
Probably with the good food that we have.
Okay.
Has a lot to do
Well
with
phrased.
it. Yes, sir. So crystals develop in the gallbladder. They precipitate out, forming gallstones, and those rattle around within the gallbladder itself. They inflame the wall of it, and that can be extremely painful from the stretch and the inflammation that occurs. Where it can get dangerous is when those stones get stuck down in the bile ducts that connect the liver to the intestines. That can present a real emergency where not only could it require surgical intervention from a surgeon, but sometimes the gastroenterologist will also assist us in extracting those stones. With prompt diagnosis, this can be managed very well, and the vast majority of folks can get through this, recover quickly, and get back to a normal life.
Okay. And then my brother recently had gallbladder issues. I think I'm the only one in the family that hasn't had my gallbladder removed. Knock on wood. But my brother had a lot of episodes where he had the pain, it went away. He had the pain, it went, and then finally they looked at him and said, "Okay, we got to take it out." Why, if there's not a stone lodged?
So the issue is those stones present a plumbing problem, right? So the gallbladder is trying to empty, and the gallbladder basically kind of aids in digestion. It stores bile. Bile helps in digestion. It's more complicated than that, but it helps in digestion. And so when the gallbladder can't empty, that's when you get the pain. So every time that you eat and the gallbladder is stimulated to empty and then it can't, that hurts. Nausea, vomiting, the pain. And so at that point, it really just becomes of making sure that we diagnose it. That's usually done with an ultrasound, then history and physical. And then once at that point, if it's not gotten infected, then it's up to the patient is when the timing is, right? Once you've had symptoms, then you're a candidate for surgery.
Okay.
But then once you start developing a white count, once we start seeing thickening of the gallbladder wall, suggestive of more infection, then it starts to become more of a surgical emergency.
Okay. Okay, good. Folks, you are listening to Doc Talk Live. We are here talking with Dr. Duffy and Dr. Cotrell about abdominal pain. And so other than surgery, there's not really any other way to treat gallbladder disease. Is that correct?
I once had a patient ask me if I wouldn't mind injecting ether into his gallbladder to see if I couldn't dissolve his stones. I refused. But
Ether.
yeah, unfortunately, once those stones form, there's really not a good way to dissolve them.
Okay.
So once you got gallbladder disease, and even if the stones were to disappear, the gallbladder wall has become inflamed and it doesn't empty well, even if those stones happen to be removed.
Okay.
So kind of once you start going down that road, there's really not going to be relief until it's gone.
Okay, and obviously you can live without a gallbladder.
Very well.
After about age 16 or so, you don't need it for part of your growth and development. One thing that's really interesting is men don't feel gallbladder pain the same as women. There's actually a genetic reason for that. We just don't sense that pain. Now, in everything else, women are by far tougher than we are. But when it comes to gallbladder, we don't sense it. So we tend to present later in the disease course.
Okay.
And the other thing is men, we're stubborn and we tend to blow things off, and it's a little bit of indigestion. So for that reason, we tend to see men have sicker or greater illness when they present to the ED than women. But again, we can address that surgically and they move on just fine.
Okay, that's interesting. But it makes sense now that I think about the patients I've seen who tend to be sicker. They tend to be male.
They tend to ignore
disease. Yeah, that's interesting. I didn't really think about it till you said that. Okay, let's switch gears. Let's talk about something that's pretty common, hernias. What's a hernia?
Simply put, it's a hole. And I think that's one of my favorite things, and I joke with patients about this. I use humor a lot in my practice. You can't remove a hole. It's just not a thing. So most patients want their hernias removed,
right?
And hernias are repaired. So basically a hernia is a hole in the abdominal wall.
Okay.
And so something gets into that hole and can cause pain, or it can cause an obstruction if it's intestine. So it can cause problems. It can cause pain, and if it's large enough, it can actually cause instability of the abdominal wall. So basically, in anyone that's healthy enough to undergo a hernia repair, we recommend they do get repaired because they only get bigger. And as they get bigger, they can cause these problems.
Huh. Okay. Is there anywhere in particular a hernia you would expect to find a hernia?
Yeah, the two most common places in the groin on either side, called the inguinal hernia. You may have heard of inguinal canal, inguinal hernias. And then the second is at the belly button. Those are the two most common. There's about 12 different potential sites that we can see it. Apart from some minor technical differences, they're all fixed essentially the same. You're closing the hole, and then you're reinforcing it, typically with some sort of mesh product.
Okay. And then who would be more at risk for developing a hernia?
So folks who carry around a little bit more weight, and that's just simple physics. If you have more weight on your abdominal wall, there's a greater chance you're going to cause a perforation to occur. Smokers, folks who are immunosuppressed, diabetics, folks who take drugs for things like rheumatoid arthritis or cancer, and then folks who've had incisions for other procedures done before.
Okay.
For example, tying your tubes, taking out your uterus, taking out your appendix. There's going to be a lifetime risk that you could develop a hernia at that incision site.
Okay. Good. And like you said, generally you're fixing the hole and reinforcing with some sort of mesh. Okay. Good. Okay, so we have that also in one of the things you talked about, Dr. Duffy. You mentioned reflux. So can we talk a little bit about what is reflux, and then how exactly does that cause pain?
If you don't mind, Paul, I'm going to pass the torch over to my partner.
Sure.
He is a local expert on this.
Oh,
and can
okay.
speak to it probably better than I can.
Yeah.
Good.
So reflux, gastroesophageal reflux, the definition's in the name. So anything that's coming up from the stomach into the esophagus is gastroesophageal reflux. In and of itself, that causes pain and burning because the stomach contents are acidic.
Yeah.
And so as it hits the esophagus is not really designed to accommodate that acid for long periods of time.
Yeah.
So after that happens, you get a burning sensation. Furthermore, one of the reasons that you can get that is a hiatal hernia. And there's some complexities of that, but basically when the stomach is up in the chest, the mechanism doesn't work properly, and that predisposes you to reflux. But the stomach also being in the chest can cause pain, the specific pain of the stomach kind of being squished.
Sure.
And the stomach squishing other things out of the way. Squish being a very technical term.
Yes.
But long story short is that reflux can cause burning and pain in that regard, as well as the compression of the stomach and the hernia itself. So it can cause pain in two different ways.
Okay. And well, since you're talking about a hiatal hernia, how does that have to be repaired by fixing the hole?
So, yeah, hiatus is basically a description of the passage of the esophagus into the abdomen from the chest. And that is just called the hiatus. So when we say hiatal hernia, it's that hole being too large, right? It's sort of it's a Goldilocks or baby bear situation. It can't be too big, it can't be too small, it needs to be just right.
Yeah.
Too small, and then you can't swallow. Too large, and you have a hiatal hernia and possible reflux.
Okay.
So does it have to be repaired? If you find a hiatal hernia and the patient's symptoms asymptomatic, then no, it doesn't. But if the patient has significant reflux and the medications aren't working, or they don't want to be on medications, or as we learn more and more, these medications have certain risks, certainly renal failure, you're aware with the proton pump inhibitors, and that's just one of the medications, then that's something that is often repaired, and we see it as a growing part of our business.
Okay. All right. And so the treatment of reflux, you mentioned the proton pump inhibitors, and then finding if it's a hiatal hernia, possibly needing to repair that. Anything else that you can do to treat reflux?
So step one, and this is something people can do at home, if they feel like they're having heartburn and they think it might be reflux, dietary modification is usually the first step. And when you see your primary care doc, that's a very good place to start, especially if it's infrequent episodes. So avoiding acidic foods, tomatoes, avoiding alcohol, obviously stop smoking for 8 jillion other reasons as well. But those dietary modifications, and there's anti-reflux diets out there as well. So that's a good place to start. Chocolate is a particularly bad thing, as well as peppermints can stimulate acid production. So dietary modifications, and if that doesn't quite cut it, then there are medications. And there's basically three categories. There's neutralizers, which are Tums, Rolaids, things like that over the counter. And then you look at a class of medications called H2 blockers that decreases acid secretion by one method. And then there's the proton pump inhibitors that decrease it by completely blocking it. And those are medications that people can take through their primary care physician. They really shouldn't be on those at home, because you can get these over the counter now.
Yeah.
You shouldn't be on those long term without a physician supervision, and have that at least looked at.
Okay, good. And then just, because we all want to know about insurance, will insurance generally cover these kinds of things, like the gallbladder, the hernias?
Yeah, that's something that we really never had a problem with. I mean, these things are very easily diagnosed, documented, and so we do have to kind of prove that to the insurance companies depending on plans, but we generally don't have any problem. Once we've documented the problem, they will cover it.
Okay, good. And then, like, say somebody's having random abdominal pain and they're not quite sure what's going on. What's the best way for them to get to guys like you? Can they just call you up and make an appointment? Or
They can always call. So it depends on the patient's insurance plan too. So if you're on an HMO, unfortunately, those make you jump through the hoop of starting with your family doctor in most cases and having referral. If somebody is on a PPO plan or something of that nature, yes, call up the practice directly. Always happy to see.
Okay, good. And then we were kind of talking about this before the show, but what kind of pain, discomfort am I looking at if you guys got to do your robotic work on me?
Less and less every day, it seems like.
Okay.
There's something we do called multimodal analgesia, which is it's become a buzzword lately, but we've been doing it for a while. And it's instead of loading somebody up with massive amounts of narcotic after surgery, you're treating it from multiple different angles. You're blocking the pain signals at the brain. You're using things like ice to reduce inflammation. You're using less sedating drugs, muscle relaxers, things of that nature. And when you combine that with a minimally invasive approach, such as what Dr. Cotrell was talking about, using the robot with tiny incisions, we've taken out colon cancers, and patients take zero narcotics afterwards. It's just absolutely astounding, even to us.
That's great.
Yeah, so not that there isn't going to still be some discomfort, but the amount of medications that people have to take and the length that they have to take them has become much, much smaller. So there's a lot of people that are very surprised at how little pain they're having these days.
That's fantastic. Good. Yes. So we're actually approaching the end of the show. So please remember to check out Facebook, Instagram, Twitter, and our website, doctalklive.com, to obtain more information about next week's show. And then like us on all those platforms as well, if you would, and subscribe to our YouTube channel. And then listen to our podcasts on Spotify, Stitcher, and iTunes. And then if you have any questions, feel free on any of our social media platforms to send those through, and we'll get them answered by an expert.